Certainly will. Thank you all. This is Chris Baumgartner here at the Washington State Department of Health down in Tumwater, and I'm very pleased to be with you again today, and I appreciate the opportunity. Feel free to interject and ask questions as I go through the content, and you can go ahead and hit the next slide. As a state employee, I have nothing to disclose. So, and these are the primary objectives I have today: to understand a little bit more about our County Profiles project and what we've been seeing at the county level, as well as how organizations can get more seamless access to the prescription monitoring program data through our State Health Information Exchange. We have some exciting updates in that arena. Go ahead and go to the next slide. So last time I was with you was in October of last year, and we didn't quite have our new data out yet, and it's always a little behind, but this is what we've been seeing for our unintentional opioid overdose deaths. You can see the prescription drugs are there in the dark blue, and heroin is in orange. And we saw the same trend in 2014. We had another nice little dip, drop down in the number of prescription opioid-related deaths in our state. Unfortunately, the corresponding increase of heroin-related deaths have left us still right around that 600 number for total number of deaths. And, you know, from the health department's perspective, we're trying to do what we can to work with partners around additional prevention activities to try to address the heroin side of this problem. The CDCs and others have noted, you know, that typically people do initiate on prescription drugs before they initiate on heroin, which makes a lot of sense. And so we're still feeling like, you know, hopefully if we continue to properly address substance use disorder and misuse of prescription drugs, that hopefully in the future will lead to also a decline in the heroin-related overdose deaths as well. If you go to the next slide, this is the opioid overdose death rate by county of residence updated to reflect 2012 through 2014. So you can get an idea of what's happening around the state. As we would kind of know, you know, it tends to be a problem just about everywhere. No one's really completely unaffected, but there are some counties that really have stood out to us as having higher rates than others. And I don't know that I know all the reasons why for that, but it's something that we've been tracking. And the interesting part is when we look at our prescription monitoring program data with things like, you know, which counties have the most opioid prescriptions dispensed per population, for example, the maps look eerily similar. So this is just something to kind of give you some idea, again, about geographically in our state what we're seeing when it comes to the opioid overdose death rate. Next slide. This is also we've been tracking, and with our hospitalization data, we can track non-fatal overdoses. And it's been exciting to see that since 2012, we've had a downward decline finally in both the opioid overdose deaths and non-fatal overdoses reported by hospitals. So we're hoping that trend continues as well, and that we see fewer folks who are experiencing fatal and non-fatal overdoses. But it was interesting that we started to have a decline in the overdose deaths in 2008 really to 2009, but we didn't experience our first decline really till 2012 with the non-fatal hospitalizations. So I did want to make you aware of what we are doing at the Department of Health. Since 2008, we've been hosting an unintentional poisoning work group, which does include public and private partners in trying to prevent prescription drug misuse. It's been expanded to include heroin, and we've really been focusing on, for several years now, on things like, you know, the prescribing guidelines, our pain management rules, the prescription monitoring program, safe take-back, the Good Samaritan law, and things of that nature. But our new health officer, Dr. Lofi, is really taken over this group and really given it some new direction, and we're really excited about what's being happening. And so this is our new working plan that we just released this January. And as you can see, we have 4 major goals. The first is along that primary prevention level of, you know, how do we prevent new people from becoming addicted to prescription drugs? How do we prevent opioid misuse and abuse and substance use disorder in the first place? And so a lot of our activities under Goal 1 really are going to be focusing around improving prescribing practices, Many of you know that we just released an update to our Washington guides last June, and following suit just about a month ago, or recently in the last couple of weeks, the CDC did release federal guidelines which very closely mimic and match ours. And so we were excited to see that. So if you haven't taken a look at those CDC guidelines, please do. They have some good resources online. Our second goal is how do we help the folks that unfortunately have developed a substance use disorder. And so that's really where we're partnering with the Division of Behavioral Health and Recovery Services to expand treatment access, whether that's through methadone maintenance or buprenorphine prescribing or different methods that can be put into place. We really realize there's a lack of treatment access in our state when it comes to opioid dependence. Goal 3 is kind of that extreme end where we have people who not only have a substance use disorder and are misusing these medications, but are at risk because of their use for overdose, and really trying to do what we can to prevent those deaths through distribution of naloxone and other initiatives. So goal 4 is really just kind of some things we can do to shore up the prescription monitoring program, but also just an overall, how do we monitor and evaluate our work to address this epidemic in our state? So if you want a copy of the plan or are interested in that, let me know. Also, this work group does meet quarterly, and it's open to participation from others. We also offer a web conferencing option if you'd like to attend remotely, so feel free to contact me if you'd like to ever participate. Our next meeting is April 26th, if anyone would like to participate in that, either in person or remotely. Go ahead and go to the next slide. So this is the prescriptions dispensed from 2012 to 2015, the top drugs by generic name, and it really hasn't changed a whole lot, but I did want you to see that we have seen a downward trend for some of the medications for the number of prescriptions dispensed. The big one is hydrocodone, acetaminophen. No surprise, that hasn't changed. The interesting one, that of course, that has popped up recently is with the rescheduling of tramadol, and now that we're collecting it, it's, as you can see, already made the top 10 and even broken into the top 5. So we really are interested to see if that ends up supplanting hydrocodone, acetaminophen at some point, since hydrocodone, acetaminophen was moved to a Schedule 2, or if that does not happen. We're not really sure, but it's been an interesting trend as we monitor just kind of the high level ones. Most of the medications, as you can imagine, probably don't surprise you. The benzodiazepines and pain relievers are there, as well as some of the ADHD medications. And then zolpidem or Ambien is sitting in there at number 4, which I thought was interesting to see that in there as well. Next slide. So this is the map I was referring to. This is the prescriptions dispensed per 1,000 residents for all controlled substances in 2014. So you can see, compared to that overdose death map, just how similar these are. And it's kind of interesting that those line up, where most of the deaths are occurring also tend to have the higher rates of prescriptions for controlled substances dispensed per 1,000 residents. So it's this type of work we're hoping to continue to do to really use the PMP for more public health surveillance work, which we're excited about. You know, not only expanding its use at the patient level where providers are making treatment decisions, but really trying to use it to better distribute our limited resources in public health and in treatment and prevention to figure out, you know, where can we get the best bang for our buck. Next slide. So I also wanted to make you aware, in case you didn't know, that the prescription monitoring program is available as a meaningful use initiative. As a public health agency, there are several public health measures, and we also have the authority or the wiggle room to establish additional registries that aren't specifically listed already, and they're just, we can kind of designate them ourselves. And so the prescription monitoring program, I'm excited to say, is not only eligible for stage 2 and 3, it's also available for eligible professions and eligible hospitals. And so you can register an entire health system with multiple sites as one registration for meaningful use. And you're able to then connect your electronic health record system through our state health information exchange to our database to directly query the information from your EHR. And so the exciting part for us with that is it really allows healthcare professionals to start being able to hopefully more effectively use the program, because they don't have to log into a separate website. They can access the information directly from the electronic health record system they're already using. So definitely look into that, and we're hoping the meaningful use will be a, kind of a great additional business incentive for making the connection, and that connection is operating and available today. Next slide. So along with that, we've been trying to figure out how to get some of the major healthcare vendors to build this connection, this transaction into their electronic health record software. And I'm excited to say that as of basically November of last year, Epic, the big one out there, has developed a transaction, a connect for their electronic health record software, which can be used by Washington customers, and it's been released to Washington customers and is available. And we were able to do that through a standard and interoperability framework sponsored by the Office of the National Coordinator at the federal level. So I was really excited we had the chance to be a pilot site with that, and we finished that testing again, as you can see, in October. And if you are an Epic customer, please do talk to your IT staff and your administration, because that update is already available. It just needs to be installed into your local instance, and you can then connect to the prescription monitoring program through One Health Port, and hopefully provide a way to more seamlessly and efficiently use the information we have in our system. Next slide. So this is just to show you a use case, so you can see kind of how it would work. The healthcare professional would log into their health information technology system just like you do today. My understanding is the PMP transaction is made part of the medication reconciliation module within Epic. And so from there, you'd be able to send that query seamlessly through the HIE and receive the response directly into Epic. And you'd be able to then have that information displayed right there. We know with how short of amount of time a lot of providers have for their patient encounters, that taking 3 to 5 minutes, to check the PMP in a separate system can be a barrier to effectively using it. So we're really hoping this will make it so that it can be more regularly used as part of patient care, and should really work nicely in your workflow with this type of integration. So this is a query from someone who has been using this HIE connection already in an emergency department. We already are connected through the HIE to 76 of our emergency departments statewide, and we're really excited about that. It actually queries the information as soon as the patient is admitted, which is really exciting. So the healthcare provider doesn't even have to click on a button even in the EHR. As soon as the patient is admitted, that request is sent for prescription monitoring information, and it's brought back into the EHR for the provider. So that's another example of how a health system could make this connection very seamless and very efficient. So just again, we have 76 hospitals that have gone live with this PMP connection in their emergency departments, and they made over 2 million queries last year. Typically, we had only averaged about 700,000 or so through our online portal. Last year, I think we did have more like 1.5, but still 76 emergency departments by themselves made over 2 million queries, which was more than we got through our single sign-on portal that's outside of an EHR. So that's really exciting. We do have a couple hospital and clinic systems in the queue for this Epic PMP interface that are working with One Health Port. And again, if you're interested, please do share this information with your IT folks or your administration about this opportunity. A new bill also passed this session that I wanted to make you aware of, House Bill 2730. It amends language in our PMP statute. So currently, before our PMP statute had only allowed access by prescribers or dispensers of controlled substances. And we realized, that some providers don't have a DEA number and don't prescribe controlled substances, but may still as a legend drug prescriber, be very interested in knowing what controlled substances their patients are taking. And so the language was amended so that prescribers or dispensers of controlled substances and legend drugs can access the PMP. So we're going to be working on implementing that. And the other exciting part is currently kind of the way our law was worded, it required us to register every individual provider at a hospital or clinic for PMP access. The new law really allows us to authorize healthcare facilities and provider groups of 5 or more, as long as they're a trading partner of our state health information exchange, which is exciting because then you can have kind of a facility level connection through the HIE a lot more efficiently. You don't have to register with the PMP every single individual in your healthcare system or facility. And so that's something we're hoping will make the health information exchange connectivity even easier to implement, not only for the department, but also for our healthcare provider and hospital systems and healthcare systems. So be on the lookout for that. Something else I wanted to make you aware of along the public health surveillance side of things is we started a mapping project we're really excited about to try to identify needs of risky prescription patterns, overdoses and hospitalizations and deaths, and identify areas where we may need more treatment resources, naloxone, where we need more doctors using the PMP, or even where we may need prescription drug disposal sites, and identify areas for medication-assisted treatment. And so this project's been funded by the federal government through a grant. And if you go to the next slide, so these are some of the data sets we're trying to include to overlap and layer together in this mapping tool. Prescription monitoring data from prescriber registrations as well as dispensing records, overdose, hospitalizations, and deaths, who is buprenorphine waived, opioid treatment programs, state treatment admission data, and then naloxone sites and drug disposal sites. Next slide. So this gives you an idea of what the mapping tool is being developed kind of looks like. It shows you prescription overdose risk, in this case, patients who are seeing multiple providers, prescribers for controlled substances. So we can kind of start looking at, are there areas of the state where more at-risk behavior is occurring than others? Next slide. So this is high dosage. So this would be looking at patients, I believe, on 120 or more than 120. So again, areas where there seems to be a high concentration of patients that are receiving high dose opioids. Another risk identifier mapping layer that we can employ in the new tool we're developing. Next slide. So this is, then you can also show up to 4 maps at once simultaneously, and they'll zoom out and scroll in the same location. So this is, you can look at high dosage, multiple prescribers, and the other risk one we're looking at is a lot of our deaths are polydrug deaths, specifically opioids and benzodiazepines, and so we have a risk indicator for that. And then you could also look at just, how many have any one of those 3, and what does that look like across the state and in different geographic areas. This is the availability of the opioid treatment program. So it'll show you basically where they're located and what kind of capacity they have, whether or not they have any openings. So that's something that's kind of cool. And then if you drill down into Seattle, one dot will kind of break into 2 if there's multiple locations within a city. And it'll show you, again, the number of facilities in that area and then the total program capacity at each individual opioid treatment program. So we're hoping that'll help people try to identify where they might be able to send patients, and also where we may need more, again, treatment capacity. So some of our stakeholders that we're really hoping will be able to use this public health surveillance tool we're developing. Medicaid officials might be able to target outreach to providers in areas where they feel like more buprenorphine waivers are needed. Our health officer might be able to target prescriber education efforts in different areas of the state where high-risk behavior seems to be occurring. Behavioral health officials can work to identify barriers, again, where buprenorphine treatment might be more needed. see, the next slide shows you a few others. A county health officer at the local level can target pharmacies for naloxone distribution where there might be a high rates of overdose. Prevention coalitions within our communities can, for example, look for areas where there's not a lot of participation in the PMP and can initiate education campaigns. Local police chiefs might be able to use the information to help seek funding for first responder naloxone training, and medical providers might be able to identify whether or not the area they work in has high rates of overdose and risky prescription behavior from patients, and can look at doing local outreach and work with their providers within their community to try to improve prescribing practices or whatever other measures they may want to employ. So we're hoping to make it publicly available. We're really excited about that project. I'm hoping it'll be done in the next couple months. And if you're trying to track me or any of my team down who is involved with this work, that's our contact information, as well as our phone number. You got our phone number and our email address and our website. We're continuing on trying to do a lot of good work in this area.